Okay, hello everyone and good evening, and thank you for being with us tonight for the 20th, actually, West Coast Interventional Radiology Club. Thank you all for being here tonight. Today we have with us Dr. Majd Ashur, who's the president of the society and also the section head of IR at King Faisal Specialist Hospital, Jeddah, and he's also the program director of the IR Fellowship. Is talking about IR management of chronic venous occlusion. And then after that, we will have two of our fellows here in the Western region, Dr. Hassan Al-Garni and also Dr. Wael Al-Hijali, who are going to show a couple of interesting cases, and then we're going to have a discussion about that. I have with me as a moderator, Dr. Azzam Khan, who is an attending interventional radiologist at National Guard Hospital in Jeddah. And just a couple of things, housekeeping information. So the speaker will start first, and then we are going to have the main talk. We will have some questions and answers after that, and then we will go with the fellow cases, and then we will have discussion as well. The program is accredited for 2 hours, 2 CME hours by the Saudi Commission of Health, the Saudi Commission, and no certificates. Everything is going to be sent or be in your account. So make sure that when you log in with your account for the Saudi Council. Thank you so much again. And without further ado, we would like to have Dr. Majid, please go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mamoon. Thank you, everybody. And it's a pleasure to be with you again. It's been a very long time since we met. I think it's almost now 1 year since we started this coronation. Hopefully, next club meeting we were to be at least, like a hybrid. We sit together and we see each other at least. Anyway, without further delay, my talk will be about IR management of chronic venous occlusions. The subject is it's going to be long because when we talk about central venous occlusions, we have upper central veins as well as lower central veins. So I'm going to just go briefly through some introductions in discussing the clinical features of each, just parallel comparing side to side. If you look at the causes, I mean, for the upper central venous occlusions and SVC, commonest is by far is the indwelling central venous catheter, whether they are dialysis catheter, pacemakers, or ports. Then also, of course, hemodialysis access patients with the fistulas that are going to create also central venous stenosis, external compression from RAB like thoracic outlet syndrome or tumors that chronically has been there, post-thrombotic, of course, as well as post-radiation obstruction. Now, when we go to the other side, the inferior aspect, the IVC as well as the iliac veins, it's predominantly into post-thrombotic syndromes from DVT and post-DVT, or due to non-thrombotic iliac vein compression from May-Thurner syndrome. There are other causes, of course, of heliocable, particularly cable obstruction from IVC filters, could be from retroperitoneal fibrosis and trauma. So, if we look at the clinical presentations, they're a little bit different. Now, when we talk about upper central veins, we talk about a kind of a venous congestions to the drainage of upper extremities as well as head and neck. So patients may have cyanosis, may have some kind of distension of the neck veins, edema of the upper extremities of the neck, of the shoulders. If this progresses, this edema, it might cause laryngeal edema, it can cause dyspnea, shortness of breath, cough, hoarseness, all these kind of symptoms that relate to the upper airway as well as oropharyngeal spaces. And patients also may have blurry vision and dizziness. Now, for the Heliocable, the symptoms will be different. It's predominantly going to be leg pain, swelling. If it's progressed with a chronic venous insufficiency, it's going to cause some skin changes, dermatitis, and venous claudication, and advanced stages and ulceration can be seen also in these kind of patients. Now, the question is to treat the conditions of central venous occlusion. We talk about chronic again. We're not talking about acute. We have to think about what do we need to accomplish with the patient. Is the planned intervention for symptomatic relief? Is it for access dysfunction or is it for access placement? we have to assess the overall access situation of the patients, upper or lower. And we have to have an expectation about durability and how tough is this intervention is going to be. And we have to look into the potential complications. These questions have also always have to look into it before we attempt doing recanalization of central veins. Now, if we look at the indication for treatment, now for the upper central veins in general, SVC syndrome, I gave you the signs. So if there is a malfunctioning dialysis fistula, and if a dialysis access is required, those are the common indications for treatment of upper central venous occlusions. For the Heliocable, I mean, you go through steps of assessment. However, if the patient comes with advanced CEP classification from 3 to 6, then you have to proceed to the intervention. But if patients comes with a CEP class 1 and 2, then it has to be some sort of management with the stocking and follow-up. Also, other indication, failed conservative treatment or advanced clinical presentations, as well as in our institution for renal transplant indications. Now, the two probably intravenous treatment options are intravenous recanalizations and extra-anatomic bypass. If we go into the technique of intravenous recanalization, now GA is preferred over sedation because these procedures are long. The pain can produce during penetration or recanalization during dilatation. And also, it's also give us some comfort zone if complications happen. Now, we have to, as we said, multiple different sites and venous accesses. So it means that we have to have the necessary material available, like long sheath from arms, legs, long catheters, angled catheters, straight catheters. The commonest wire is by far is glide catheter hydrophilic wire. I mean, so this is, again, very important. We have to have a target point sometimes if we need to do access from both sides, whether a snare or balloons. And of course, variable size of balloons and variable sizes of stents. We have to understand that to do intravenous recanalization, it can be very difficult because of very significant collateral pathways that are visible. So multiple oblique views sometimes can help in these cases. And we really have to be patient when we do this kind of procedures. Let's just start with a case here. There's a 50-year-old male patient with an interstitial disease on hemodialysis through right brachiocephalic AV fistula. He had a right arm and neck swelling with high venous pressure and pain during dialysis. And this is a typical appearance of the arm swollen a little bit diffusely. You can see it a little bit with some brown pigmentation, and slightly can be red also. Now, in our centers, probably we do the largest number of renal transplant in the Middle East. Annually, 220 renal transplants are done. So we have a lot of renal dialysis patients that come to our hospital and referred. So this is the fistulogram for the patient. You can just see there a central venous occlusion. First, to start with, this cephalic arch, there is a significant stenosis, but there's a complete occlusion where there's no even blood seen in delayed images communicating this occlusion to the SVC. So we, of course, we access the right, the fistula itself, and you can see the catheter here. We've tried to manipulate antegrade D using 5 French vertebral catheter and the trauma wire. We couldn't, and we went, of course, retrograde, and you can see the distance between the two sites. And we managed, of course, then to go retrograde D using trauma wire and the catheter. The best thing whenever we do a venous intervention, we have to have a back through and through wire in order for us to have some sort of enough support to advance the balloon and stents through very tight strictures. And you just continue the procedure by doing a gradual balloon dilatation until you achieve results. If the results are good and optimal with no recall of stenosis, this is optimal. We don't want to put any stents across this area, particularly costoclavicular junction. This is a happy picture for us and for the patients. This is, you can see post recanalization images, as well as this is the arm of the patient. Next day, we went there and we saw the patients. Now, what are the studies showed about central venous recanalization using conventional method, like just simple wire and a catheter? Technical success rate is ranging between 50 to 100%. With a primary patency ranging between 40 to 67% at 12 months. Stenting should be avoided in general. However, it can be used if there is a recall of the stenosis. Of course, if there is a rupture, you have to put a stent graft. And we have to be careful and avoid covering uninvolved veins. So we try our efforts not to cover some veins that are patent and compromise access in the future. Now, reintervention for these cases are frequent in general in stent restenosis, stent fraction, and reocclusions are common also complications of these kind of recanalizations. Now, another case, 49-year-old male patient, again with the same stories, presented with progressive facial swelling this time and flushing, but no helical blurry vision. He was referred from outside facility after failed central venous recanalization. These are the information given to us, occluded right brachiocephalic vein and as well as upper SVC, occluded bilateral interjugular veins, left axillary junction with the lateral subclavian veins. These are all occluded. The patient had an old non-functioning left AV arm fistula. He had a patent lower central vein. So you can see only patent lower central veins and the AV fistula in the right upper arm that we can go and access this. You can just see this, we access the fistula through the basilic vein, of course. This is the occlusion here. And then, of course, we've tried to go with a trauma wire, and we could not go to the SVC. However, then a channel was open to the left subclavian vein. We've tried using the source omni to have a reversed access backward to the SVC. However, after several attempts, we could not. Of course, this is the access we put from the right femoral sheath. You can see the distance between the occluded or lower superior segment of the SVC patent and to the inferior aspect of the central venous occlusion is a little bit long, about 2 to 3 centimeters. Then we've tried with, again, with the true wire, we couldn't. Then we've tried like a sharp recanalization. Usually I take the V18 and I cut the floppy tip and it becomes like a needle. And I use the vertebral catheter, I like from Cordis because it's a little bit firm. And you just guide the orientation of it. We managed to go through the occlusion. We had a snare there, of course. And then we snared the wire. And once we have back through and through, we started dilating the right brachiocephalic vein to SVC. And then, of course, we managed also to go and dilate the left side. This is how it looks after dilatation. Of course, there's major recoil. So we ended up putting 2 stents, and we had a good outcome after this. Looking into this, I was looking at what kind of materials. You can see tons of materials. We used lots of catheter sheath, and it was not unnecessary. It's all necessary. We had access both groins, bilateral femoral. We accessed right brachiocephalic fistula. We used the stents, balloons, high pressures. We spent about 3.5 hours of procedure time. Use the GA. We always do GA. These cases under anesthesia. Because of the prolonged procedure, patient also comorbidities, usually they go to the ICU. Now, but the good thing is about that, we improved his symptoms clinically. We saved fistula, otherwise they would ligate it, and they would have used the lower central veins, which would prevent this patient from having a transplant. This patient is already now on a scheduled renal transplant. So an effort made that's worth it, definitely. Now, sharp recanalization was first described by Gupta in 1998. And it included using a Sheba needle through a sheath dilator or metal cannula. It's been reported using all different types of tips needles, transeptal needle, back end of stiff trauma wire, outback devices, and cut end of V18. If you look at the data there, it shows the success rate between 87 to 100% of the time. Major complications being reported, including stabilization, hemopericardium, pneumothorax, arterial injury, nerve injury, ventricular fibrillation, as well as death. Now, other techniques of doing more advanced recanalization is using a power wire radiofrequency guide wire. We have no experience in our center with this. However, this technology is just, of course, we know the radiofrequency, it emits this heat, and this heat gradually penetrates through the occluded vein, and you have to have a target with a balloon or a snare there in the other side of the patent vein. Now, it's been reported the success rate ranging between 69 to 100% of the time, and it could be helpful for a long recanalization, for recanalization of a long occlusions. Now, major complication was similar to sharp recanalization. However, a tracheal perforation has been also reported. Now, extra anatomic bypass, this has been reported mostly for occlusion of the cephalic arch or thoracic outlet syndrome. So it's just to bypass the occlusion at this location. In this type of procedure, you have to have a patent central veins, or at least you have to have an access to it through jugular or supraclavicular innominate veins, and then you can create this fistula again percutaneously from the either central veins or actually there is this AV fistula, and then you can get this through. It's been reported and with a technical success rate of 100% and good primary patency as well as secondary patency, considering these patients in general are not doable in the past. Now I'm presenting this patient as a 42-year-old male patient, again with the same story, interstitial disease on hemodialysis is done in outside facility through the left IJ Permacut. This Permacut was placed 6 years ago. It's a record actually. I've never seen a patient with a Permacut that lasted that long. It was referred because of left neck and shoulder and arm swelling, and he had actually a left brachybasilic AV fistula created a year ago. However, that was not used because it was not superficialized. And you can see this is huge collateral veins across the neck. At some stage, they thought this is a thyroid lump, and you can see this Permacut. So the history, the patient also had a rejected renal transplant, has an existing functioning liver transplant, history of seizure, tertiary hyperparathyroidism, have ischemic heart disease, cardiomyopathy, as well as scoliosis. You can see those cases, they always, and almost most of the time, they come with a very complex comorbidities with them. So what we plan for this patient is actually we plan to remove the Permacut, dilate the tract, and see how if it communicates to the left axillary and subclavian veins. So we struggle honestly at the beginning is just to remove this Permacut. This was very incarcerated inside the patients. So I could not pull at all. We had assistant. We were two consultants and fellows, and we're trying to pull this back and forth until even you can see here, because of the liver transplant, there is a major angulation of the IVC to the right atrium. But anyway, so we managed to have this Permacut back and forth until we managed to get it out safely. This is the injection of putting the sheet in the tract of the Permacut. You can see that there is nothing communicating to any veins. And this injection is from the sheet that we placed through the fistula. And you see its occlusion is not communicating directly to this SVC. It's actually going all across the chest, neck, then to the SVC. So we've tried manipulating this, and we did a lot of different techniques. We would try to go from the IVC below. We used from the beginning the track of the Permacut. We tried to use this sharp reconnaissance with the V18, pushing it. Actually, we failed all the options. We failed. Then we did a gun side technique, putting a snare from here, a snare from there. So this is completely, it's not like actual vein. There's an extra anatomic. We went from the neck axis, and we punctured these two snares, and then we managed to have reconstitution of the flow from the left arm fistula to the SVC. Luckily, we did not have to put a stent because the flow was very good and all the collaterals subsided. So this is the X-ray of the patients done in April 14, and that was the first time this Permacut was placed. So after 6 years almost, we removed this Permacut and we replaced the Permacut. Yes, it took 4 hours. Yes, it's the same Permacut, but however, hopefully, of course, clinical improvement that was significant when we saw the patient next day, and the patient is planning for superficialization of left brachybasilic fistula so that it can be used. So there are a lot of cases that we're going to go through. Maybe the time, yeah, we still have a lot of time. Now, this is another case, a 56-year-old male, again, the same story, interstitial disease, referred for renal transplant. Had a hemodialysis through right common femoral Permacut, and he has occlusion of the IVC and bilateral common iliac vein. This is in the past, occlusion of the IVC and bilateral common iliac veins, as well as right external iliac vein. He also has occlusion of the bilateral brachiocephalic vein and upper SVC. So the plan was first to recanalize the upper central veins, and once we secure this by just putting a dialysis catheter, then a second stage will recanalize and angioplasty the iliac veins and IVC in order to have this patient eligible for a transplant, renal transplant. So this is, again, we started, this patient has a patent IJ, so we went through this and you can see the occlusion. We tried to use the standard technique, conventional trauma wire. We couldn't recanalize. You can see here a little bit of a contrast in extravasation. So we've tried from right side antegrade, we could not. Then we tried from the left side. So his left IJ was accessed. You can see the brachiocephalic vein is stenosed, but then completely occluded. We managed to recanalize this with a wire. You can see all those collaterals. We managed this to go with just a trauma wire and 5-inch vertebral catheter. And then we did a minor gradual dilatation as usual. I usually sometimes start with a 5 or 6 millimeter, then we went to the 8 millimeter. And again, the intent here was not to have a perfect picture. The idea was here just to place Permacut. So during this time, the patient, after we deflate and we remove the balloon, the patient had a sudden drop in his blood pressure with increased heart rate and has a pulsus paradoxus, which means there was a drop in the blood pressure during the inspiration. Of course, this patient is intubated, as you can see. And of course, immediately we suspected either two things: is there is either a rupture to the mediastinum, or anesthetist immediately inform us that there's a restriction to the heart. Now we have to know the complications. So this injection during the arrest, quickly we injected to look if there is a leak that we conceal. At that time, we could not see a major leak, but then we did an ultrasound transthoracic subxiphoid. We found, of course, pericardial bleeding. We had to put a small tube at the beginning, but the patient continued to reaccumulate. We ended up putting a pigtail catheter at the end of the day after maybe 2 hours of resuscitation. Luckily, alhamdulillah, we managed to patient was recovered very well. Of course, cardiac surgeon was a consultant. They took the patient to the OR, and actually they found the tear. In retrospect, was looking at this, it was he described the tear is exactly at the SVC right atrial junction, was probably here is the tear, because that's the valve. So this is probably where the tear was there. He managed to suture it, and they put a graft from the left subclavian to the right atrium. This is the graft. Patient is using his left, they created the fistula in left arm and is using the fistula in the left arm. He decided not to go for a transplant for the time being. So life cannot be easy all the time. It can be really difficult, but we have to be ready and be prepared. And we have to know exactly what complication can happen. So hopefully, inshallah, a patient will not lose their lives on our table. Okay, so a nice view of Fountain of Jeddah. Now we're going to go to the chronic Heliocable occlusions. It's going to be a shorter presentation. This is a patient, 31 years old female with a history of left leg DVT in the past. She had left leg swelling and claudication, not improving conservative treatment. And she had chronic iliac vein occlusions. I really like the MRV in the lower extremities because it's really give you a very good map. And you can just see the occlusion here. The common femoral vein is patent and everything else is occluded. Now, for lower extremity, in general, Heliocable occlusions are a little bit different from upper. Upper usually shorter, and we're talking about even the longest one, maybe about 3 centimeters, 4. But in here, usually the occlusions are very long, and you need some kind of a pushability. If you look, this is a frontal view. If you do oblique views, you're going to see where the knob is. This is the key. Once you go into the knob, sometimes the wire will not go. So I like to use a small caliber balloon, 4 millimeter diameter, whatever I can push, and just minimally inflate this balloon, and then try again to continue recanalization, because that will really give a good support when we push the wire. Again, I like to rotate the wire, not just shove it inside. The trauma wire for the IVC and iliac, I personally prefer the straight end trauma wire, not the curved, the regular one. Once we recanalize, again, we do gradual dilatation for the entire occluded vessel. Of course, then you have to localize where is the contralateral iliac vein, and then you put your stent, of course, likely needed most of the time. Another patient who had renal transplant in the left side, and she was very symptomatic from the right chronic venous occlusion. So same kind of a scenario. Try to use oblique views, that will help you. Sometimes when you push and you find this small curve in the wire, just keep pushing it gently, not to have a very large loop. That usually goes intraluminal nicely and open the vein. And again, you go through gradual dilatations and again, confirm the site of the iliac confluence and put your stents. Now, stents for the iliac veins, the different types. You can use self-expandable. This is a commonly used. You can use balloon expandable, especially for areas like the upper aspect of the common iliac veins. There is no issues of it, but we don't use it at the lower external iliac veins because there could be potentially compressible. Of course, cover the stents, you have to have it available in case there is kind of a perforation and complications. In general, it's recommended to oversize stents in the venous system, 20 millimeter diameter at the IVC, 16 common iliac veins, and 14 to 12 at the external iliac vein. Now, the landmarks for the stenting, now the confluence landmarks, you can, of course, injecting the contralateral and see where is it. You can use a fluorophade or whatever modality you have in your system. Or, of course, in general, as a guidelines for the left side, don't go beyond the left, don't go beyond the spinous process of the spine, because otherwise you'll be in the SVC. Now, going into the SVC or not going to the SVC, there are a lot of debates. So some people recommend that you go to 1 to 2 centimeters into the IVC, and some people say, no, you have to stay within the common iliac vein. Now, looking at the literature, this is a systematic review. They looked at lots of studies available, and there was no consensus. There are lots of papers say there's no change in the patency, and there is no change in the contralateral limb DVT. However, other studies showed that there is a 1.1% risk of contralateral DVT if the stents protrude inside the IVC. Other also report confirm or concur with that, but other reports also showed no. So there is no consensus. You're going to see some people put their stents inside the IVC and other people try to. Of course, the compromise, if you don't go to the IVC or you go beyond the occlusion, above the occlusion, the stent gonna collapse and occlusion can happen. And if you put it way up, there is a risk of you compromising the flow of the other. So this is the problem. Now, I'm not going to discuss femoral, of course, DVT, but putting the stents below the inguinal ligament or not, again, there is no consensus, there is no agreement among many studies published whether you put it below or, across the inguinal ligament or not putting across the inguinal ligament. Again, this is the issue mostly between not covering well the occlusions and having the venous occlusion and having a stent occlusion versus compromising the flow of other vessels. What are the recommendations for post-procedure anticoagulations? Is to use a low molecular weight heparin for 2 weeks, and they use oral anticoagulation for about 1 year, and then aspirin for life if stents are used. Lots of protocols, but this is some sort of an agreed protocol among many authors in the world. Now, the technical success or the technical outcome of heliocable recanalization is high, 83 to 95%, with a 4 years primary patency between 23 to 98, and secondary patency between 66 to 96. And this very wide range in the percentage is attributed predominantly to the cause of the occlusion, whether it's post-thrombotic versus non-thrombotic from like Mayne syndrome. So the poorer outcome will be in the post-thrombotic syndrome patients. Now, what is about the clinical outcome? Pain relief from 86 to 94%, swelling relief of the lower extremities from 66 to 89%, ulcer healing in advanced disease can be up to 100%, although these percentage based upon sometimes small reports. Other, of course, benefits of this, maintaining dialysis access as well as relief of pelvic congestion syndrome. Now, what are the major complications? Reported major complication can up to 8.7%, contralateral DVT in 1.1%, stent migration up to 4.3%, stent occlusion in DVT from 3.8 to 34%, and however, significant bleeding is rare, not like the central venous, upper central venous recanalization. And stent-related complications like fractures, erosion, restrictions are very extremely rare, again, compared to the stents placed as the costoclavicular junctions. This is when sometimes we get a patient that they have nothing up, and they had some sort of a Permacut in the past, or they removed the Permacut. You come and you see a central venous occlusion. You can see here the entire IVC is occluded. The purpose here was just to place a dialysis catheter. So usually we just do balloon dilatation, and then we place the catheter. This patient I'm going to present is 21-year-old male who's again in surgery disease on hemodialysis referred from outside facility. This patient had a tunnel dialysis catheter through right common femoral vein and was removed due to infection. Had left AV fistula, not used for a long time due to central venous occlusion. You can just see here, this is the catheter. This is old image before they remove it. And you can see there is no inferior vena cava around it. The infraazygous, of course, SVC is patent. However, this left brachiocephalic vein is occluded. So for this patient, the plan was to do 3 stages. Number 1 is again, he was referred for a transplant to our hospital and to manage this very complex patients. This patient, first we did upper central venous occlusion. You can just see here the occlusion. This we managed to do this with a traumoir and a vertebral catheter again, gradual dilatation, and we restore the flow in the upper extremities in order for the fistula to be used. And then we did IVC recanalization. This was a very long, actually, occlusions. Even the iliacs were occluded. And you can see again, I use sometimes small balloon to support pushing my wire. And we managed, this is from a superior aspect we access. And you can see here, occlusion of the IVC is only the hepatic veins drain into it. We managed to use a sharp recanalization a little bit using this technique of a V18 wire, or and then you put a snare. It's always advisable to have a snare in the other side, especially if using a smaller wire, to have a very good tension over the pushability of our balloons. Gradual dilatation, and then you stent the entire thing. This is the stage 2 we completed. Patients later on, I think after 8 months, he had successfully his renal transplant. This was in 2019, his renal transplant. Until today, alhamdulillah, it's very functioning. So this is, we converted the patient from a hopeless case into renal transplant as young patients. This is a patient who's 34 years old, again referred from outside facility with a non-Budd-Chiari syndrome. Had antiphospholipid syndrome as well as DVT for the past 9 years. This is the CT when she was referred to us. You can see this hepatic congestion, no IVC at the intrahepatic portion, as well as there no IVC below. There is only IVC segment between the renal veins as well as subhepatic IVC. Everything was occluded. You can see lots of collaterals here in the lower abdominal wall and posterior back. It's the ascites, so she has the picture of Budd-Chiari. She was referred to us with the intent that we can either do a TEPS or venous recanalization. So when we scanned her sonographically, we found the hepatic veins were patent, so we managed to go through it. You can just see the with severe obstruction. We tried to go back and forth until we managed again to use the sharp recanalization of a cut tip V18 wire. And again, we put a snare, we dilated this, and then we put a stent just to have a good hepatic venous outflow. So this patient was referred back. She was followed, of course, by our gastroenterologist. All her parameters, everything, liver function went to normal, ascites disappeared, everything, she was happy. But then she started, of course, after all this resolved, she started now to suffer from the symptoms. of chronic venous occlusion involving the IVC. She had a chronic pelvic pain and heaviness, pelvic congestion syndrome kind of a picture. She had a significant lower leg pains and significant visible varices in her lower abdomen as well as in the vulvar region. She was very unhappy about that, and she wants this to be fixed. And so this is the picture of her. This is the injection barely. There's no external iliac vein, even the sheath was barely placed through something. You can see there's no IVC, nothing at the lower segment. And then once we managed to cross this with a trauma wire, you can just see the renal veins here, and this segment is widely patent, and then is again occlusion at the interhepatic portion. We've tried using the trauma wire again technique, and we managed to have a wire here. However, when we injected the contrast, this contrast was definitely not in the right atrium because this is definitely outlining it. So definitely this is a hemopericardium. We abandoned the procedure, we put a coil, and she was clinically stable. We always do our patients in RGA, but she was stable during the whole. She was followed up in the next few days by having a transthoracic echo, and she recovered very well. We brought the patient 6 weeks later because she still was, she wants her lower extremities symptoms to be resolved. Again, of course, because we did not do anything for the lower, we had to recanalize again, but that was not difficult. We tried again to go to a retrograde recanalization, but it was going to the false track still. So then we went an antegrade. We tried to use the trauma wire, we couldn't. Then we used a cut tip V18. We went through liver, we put a snare here. Again, we couldn't direct it really more medial to the patent SVC. So we used for this case an outback device because it diverted the needle away from the track into the to the IVC. Again, then we angioplasty, we put a stent, and we saw her in the clinic at several occasions. She's very happy, and all her symptoms are resolved. So to summarize, what we have to do is, and we have to know that we have to have a clear decision and documentation. What do we need to accomplish for these patients? Do we need to plan to relieve the patient's symptoms? Do we need to have, do we need to manage access dysfunction, or we want to have an access placement? This is very important that because then it will push you on how much aggressive you're going to do and how much you want to get really a great recanalization. We have to evaluate all options and overall access sites. If the patient is already in dialysis or doesn't have a kidney problem, even you have to have a good imaging and mapping of the central veins, whether lower or upper. You can use MRV, you can use CT, whatever you can use in your facility. And prepare your needed material. We always have to have a plan A, then maybe plan B, or even sometimes plan C. But in general, you have to have 2 plans. If this failed, what you will do and what material you will use. Make sure you have all the needed materials available. Expected durability. How tough is this? That will really tell you sedation may be just enough for this short maybe procedure, a less aggressive kind of intervention, or you really need a GA, needs ICU, you need to inform the cardiac surgeon about these cases. Know the potential complication to avoid them, or be ready to bail out. You should have large balloons to seal the perforation if it happens. You have to have a cover stents, support team, and our team. That's it. I thank you very much for listening, and I will stop sharing now my computer. I think I'm on time, inshallah.
This was great, very extensive. I expect like a little bit here, a little bit there. Mashallah, you did the upper, you did the lower, you did like the transhepatic, you did everything. It's more than what's expected. Allah ya'tik al-afiyah. I think we have many questions, but we'll just go with one for the time constraints, because we have, as everyone knows, the General Assembly after this, and then we'll move to the fellows cases. Azam, any question?
Yeah, Allah ya'tik al-afiyah, Dr. Majid. It was really comprehensive procedure, presentation. And actually, I am through the presentation of Majid, I have also can show some of like technology to use it for recanalization of some vessels, which is included is like it's off-label. We can use it. It's in our tools. when we don't have RF wire, or we have others, other tools are when failed.
Thank you.
Hey, so one question we have is, one question is, do you inflate a balloon and then you actually do it for the recanalization, use the same balloon to recanalize?
What was the question? I couldn't.
Like if you, for example, sometimes you actually inflate the balloon to stay in the center. So if you're in the vessel, then you actually inflate the balloon to be in the center to know your path, I guess.
Yeah, I use this mostly, honestly, in the IVC, in the iliac veins, because it will give a support, or sometimes in the IVC. And I use the same balloon, just only to push. Once I see the wire is going, I just keep pushing, just a minor inflation, just to have it stable, because the catheter are flimsy sometimes.
Okay, excellent. I mean, as I said, many questions, but I guess we have to move to the fellows to see their great cases as well. So 5 minutes per case, and then we'll have the questions at the end. So let's start with Wael, Dr. Wael Al-Hajeli. He is a second-year fellow at National Guard Hospital, Jeddah. Please go ahead.
Assalamu alaikum. I'll present a case. This is a 45-year-old lady who presented to the hospital with left leg swelling and labial varicose. Doppler ultrasound performed through 2011 to 2018 showed thrombosis of the iliac vein. Although the patient was on therapeutic anticoagulant, there were no resolution of the thrombus, for which a CT scan was performed to rule out mitral syndrome. This is her CT scan done in 2018, which showed compression of the left common iliac vein by the right common iliac artery with thrombosis of the common femoral vein, as well as multiple labial varicose. The patient referred to interventional radiology for venoplasty and stenting. This is a venogram, which showed multiple collateral vein and the occlusion of the femoral and iliac vein with multiple collateral vein, as well as multiple varicose in the pelvis. Venoplasty through the internal jugular and popliteal vein was performed using multiple size balloon. This is the picture of the venoplasty. There were still, after the venoplasty, there were still areas of stenosis in the common femoral vein, for which stenting of the common femoral vein using veno stent was performed. However, no stenting of the iliac vein was performed at the first time, as the patient due to technical reasons, and the patient has been rescheduled for second session for stenting of the iliac vein. This is the post stenting of the femoral vein. However, the patient didn't show up till 6 months with history of recurrence of the symptom in addition to a BE. So we brought the patient back for stenting of the iliac vein. Venogram was performed through the internal jugular and popliteal approach which showing complete thrombosis of the previously placed stent with occlusion of the iliac vein, as well as multiple collateral veins, and reappearance of the varicose. We have tried to recanalize the stent using sharp recanalization technique, which failed, for which we have used another technique using a long sheath, which was advanced through the popliteal approach, followed by advancing of the Rotarex, which is the arterial thrombectomy device. This is the image, just a second, sorry for the.
Two more minutes.
Yeah, this is the Rotarex device, and using the Dyna CT to confirming the place of the catheter and the Rotarex device within the stents. After we pass the wire to the common iliac vein, a snaring of the iliac of the wire to the snaring of the wire was performed. This was followed by placement of deploying of the CaptureX device from the internal jugular approach, and then we have performed angioplasty using different size balloon. With stenting of the iliac veins. This is the end result, which is a patency of the iliac and femoral vein, and resolution of the collateral vein, as well as the pelvic varicose. So take-home message: stenting should be done in one session. Rotarex, which is arterial thrombectomy device, can be used off-label for venous recanalization. Dyna CT can be used to guide the recanalization. Thank you.
Thank you so much, Wael. We'll have questions if we have time at the end, but there are many questions, I guess, on the case, and it's a very interesting case. Hassan is the second-year fellow at King Faisal Specialist Hospital, Jeddah.
Assalamu alaikum warahmatullahi wabarakatuh. I'm presenting case. This is a 33 years old gentleman with a positive familiarity of breast disease. He has been diagnosed with a breast disease at outside hospital with perioral and genital ulcers, and he developed left popliteal fossa mass associated with claudication. Popliteal artery pseudoaneurysm was diagnosed, in which stent graft was inserted, which was complicated with the pseudoaneurysm expansion and migration of the stent. So the patient was referred to our center because of multiple pseudoaneurysm, one at the celiac artery and the other at the right common femoral artery, and the third one at the left popliteal artery. So the case was discussed at the vascular MDM, and the decision was made for to admit the patient urgently and to do CTA with the chest, abdomen, and pelvis, and the MRI of the brain to exclude any other pseudoaneurysm, and to do a rheumatology consultation. And for the right common femoral artery pseudoaneurysm, the decision was made to do thrombin, ultrasound guided thrombin injection. Regarding the celiac artery pseudoaneurysm, a decision was made to embolize it by a glue injection and stent grafting of the celiac artery, and the left popliteal artery pseudoaneurysm can be fixed surgically. Seen by rheumatology and start on medication, and once the inflammatory markers CRB and ISR were normal. Conventional procedure were carried out. The patient initially was brought to the angio suite, and ultrasound-guided thrombin injection was done. And as you can see at the last image, there was no more filling in the pseudo-aneurysm. Unfortunately, the follow-up ultrasound one day after showed the filling of the aneurysm, of the pseudo-aneurysm. So the patient was brought to the angio suite for celiac artery pseudo-aneurysm embolization, plus another thrombin injection of the right common femoral artery pseudo-aneurysm. Access was obtained from the left common femoral artery, and the catheterization of the celiac trunk showed the large pseudo-aneurysm, as you can see at the provided images. And another access was obtained from the left brachial axis, and catheterization to the stent to the sac was done by macrowire. And from the femoral approach, or from the femoral axis, a stent was deployed across the celiac artery, which was successfully covered the pseudo aneurysm, and decision was made not to inject glue into the pseudo aneurysm sac. And for the right common femoral artery aneurysm, balloon was inflated at the site of the neck, and ultrasound guided thrombin injection was done, and the pseudo aneurysm was disappeared. Unfortunately, this patient, he developed the left brachial artery thrombosis, in which a surgical thrombectomy was done. And after that, the CTA of the chest and MRI of the brain excluded any another pseudo aneurysm. 1 week after, the patient was follow-up was done and showed refilling of the celiac artery pseudo aneurysm. And as well as the refilling of the right femoral artery pseudo aneurysm. Again, the patient was brought back to the angio suite, and access was obtained from the left brachial artery. Angiogram showed no filling of the pseudo aneurysm, so the decision was made to access the pseudo aneurysm sac from the right posterior translumbar approach. And the access was obtained, and by gauge spinal needle injection was done using a mixture of levodopa and glue, and the conclusion angiogram showed the filling pseudo aneurysm. Again, unfortunately, he developed the brachial artery thrombosis, and he was taken to the OR. Thrombectomy was done, as well as right common femoral artery pseudo aneurysm surgical repair. He was discharged home and admitted after around 4 weeks for elective popliteal artery bypass. And after the bypass, follow-up CT was done and showed again refilling of the pseudo aneurysm, as you can see at the profile images with the stent and glue. So the patient again. The case was discussed again with the vascular surgeon, and the decision was made to deploy another stent at the celiac artery with more extension into the aorta. From the left common femoral artery approach, catheterization of the celiac artery was done, and another stent covered stent was deployed, which was extended into the aorta. The follow-up CT at the third day post the stenting showed no more filling of the aneurysm, of the pseudo aneurysm, and no more right common femoral artery pseudo aneurysm.
2 minutes.
The patient, he has a regular follow-up with the hematology, and he is receiving prednisolone, azathioprine, colchicine, and infliximab to control his disease. And this is the follow-up 4 months after the endovascular treatment of endovascular approach for the aneurysm. the ischemic artery pseudo aneurysm helicristin of size with no more filling, no more aneurysm at the right femoral artery. And thank you.
Thank you, Hassan. It's a nice presentation, nice case.
Thank you.
Any question, Dr. Mahmoud?
No, it's great, actually. Unfortunately, we have the General Assembly to follow, but those cases are great. I wish if we have more time to actually have more discussion. I have many questions myself on, like to Dr. Ashur and also to Wael and also to Hassan. I mean, Hassan, I know the case, but there are many things that we can discuss. But I think we have to wrap up just because of General Assembly. But great case. So we have Meth-Turner with many questions, and then we also have Behçet disease, which we don't see every day. I was gonna, defer to a next meeting, but unfortunately, because they actually prepared it and we've been hammering on them, just, you have to do it, you have to do it. So we had to give them the opportunity to present. So I really appreciate it. Thank you so much, Dr. Ashur, for the presentation. Thanks for the fellows, Hassan and Wael. Thanks, Dr. Azam, for moderating. Any question or any comment from the speakers?
Okay, thank you very much for hosting us, Mamoon and Azam. And hope, inshallah, ya Rab, next time we'll see each other in front of each other.
Inshallah, قريبا.
Inshallah. We were actually about to do that, but then after the last weekend, I mean, we had to do it virtual, but we waited until today to do it as such. But thank you so much. Enjoy the rest of the night. We appreciate it. Thanks a lot for making our 20th West Coast Interventional Radiology Club successful. Thanks a lot. Have a good night.
Thank you.
Thank you.